Well, I would like to think that this was our first recording. Well, I will say yes, because the other one was just with my crew. We did our little shout out. So, but this is the first with our special guest, Dr. Heather Bassett, and she is the Chief Medical Officer at XSOLIS. And if you would, of course, I'm Michael Mann, the host of Planetary Health First, Mars Next, and we talk about anything and everything, a lot with technology, of course, healthcare at the core. And so we're really delighted you're here. Could you just quickly, briefly introduce yourself? That would really help. Really, thank you.
Yeah, and very excited to be here. I'm looking forward to a great conversation today, particularly around artificial intelligence. You can kind of it's definitely an area I like to speak to because I think there's tremendous opportunity. But my name is Heather Bassett. I am the Chief Medical Officer at XSOLIS. I've been with the company since we started back in 2013. So I'm sure, as you can imagine, I've worn a lot of hats, from sales to overseeing clinical teams. Currently, I do oversee our data science team. And they're the ones responsible for building the AI models that we feed into our platform, which is not the typical kind of arrangement. A lot of times, data science reports up to chief technology officer. But I, as I mentioned, really enjoyed this space. I actually went to Carnegie Mellon way back in the day, doing both biology and computer science. So I kind of like to think of this as bringing things full circle.
I'm glad you introduced yourself because that helps give some context. 2013, I guess you weren't using AI in your company, were you not?
No, not back in 2013. We were, we started in the denials space. So, I'm sure you're familiar with denials happening on the back end by payers, and then there's a lot of back and forth to try to get that appeal overturned. And so we recognize that, if you made changes on the front end, if you use data-driven techniques to identify areas of opportunity or areas of risk, you could mitigate a lot of the work that's happening on the back end, a lot of revenue escape that happens just because of manual work.
This is all unscripted, and you just made me think a second ago. I was helping my mom a little bit ago. We have my mom's 86, my dad's 92. He's been in hospice. This is his third time around, and he was denied, and she won an appeal. So I told her just go ahead and appeal it. He had some significant fall, some declines, status with food intake and whatnot. It just seems like a lot of the stuff wasn't entered into the chart. So anyway, shout out to my mom, I guess, right?
Yeah, huge shout out to your mom, and you do have to be proactive in healthcare. And I'm a big fan of hospice and palliative care. I think actually, if I had not gone into working with XSOLIS, I probably actually would have gone down the path of palliative care because I found that very rewarding. But I think actually what you just spoke to speaks to a lot of the problems in healthcare. There's multiple reasons that claims are denied, and one big one is around transfer of information. Mm-hmm. And a lot of times it's just the either information was not shared appropriately or it was missing a crucial piece. And that's where we see a lot of opportunity is kind of how can we help align both sides of the house there, and use, and in our case, we use AI to help kind of be the intermediary and then help with ensuring you get the appropriate information to the payer, because there's so much, there's huge waste there. Mm-hmm. There's a lot of work on both sides. It's duplicative work, and so you get a lot of that administrative burden. And then unfortunately, like you just mentioned with your mom, it's the patient that ends up, kind of having to then put in another, layer of effort, which is added stress, particularly, when you're dealing with hospice and things like that.
Well, I'm really glad you're here, Heather, and especially I think it's cool your role. You're internist, you're board certified internist, but then also from Carnegie Mellon, that's no light name in the heavy engineering and sciences. And so, did you say computer science? You got a degree in computer science as well?
So let me back up and caveat that a little bit, and this will kind of speak to date myself here as well. So I went to school at Carnegie Mellon in the late 80s, early 90s. So that was really when, like, I was lucky to have a computer at home. That was not, the norm. The internet wasn't really around. There's no cell phones. So I was introduced to programming in high school, and I thought it was just fascinating. You could write, code, and the computer would, like, create a game for you or something. And these were nothing like what you do today. It was very rudimentary. But I went in because I just like to solve problems, but I also had an interest in biology, and so I did a dual major originally. But then I decided halfway through I didn't want to be in front of a computer all day. So, I mean, what do I do now? So I dropped the computer science part, continued the biology. I did basic science research for about 7 years in DNA repair before deciding to go to medical school, and then ultimately ended up at XSOLIS. So I kind of call it, coming full circle, like I was destined to come back to the technology piece.
And you'd probably be practicing medicine more if you didn't like computers, right?
Oh, true. Oh, yeah.
With I don't mean to joke, but like 15 hours or whatever. Gosh, could we say like about 33%, 30% or so of the time clinicians?
Higher. I think it's higher than that. I mean, and I'll be honest, that's part of the reason. So I used to work as a hospitalist. So I loved acute care medicine. Really enjoyed working in the ICU. That kind of higher intensity, really interesting patients that you take care of kind of at their sickest moment. So I really enjoyed that, but I just felt like I was being pulled further away from the patient. And a lot of that was, the busy work, the administrative work you have to do, inputting information into the electronic medical record. And electronic medical records were originally built around meaningful use. And so to meet government requirements, and the physicians, nurses really had no say in how they were built. So they were built primarily as billing tools and not around like my workflow as a physician. So they're just kind of like, they're better now, but it was still very, it's very frustrating. I mean, there's great memes out there about, I love a good meme. That's my backup CMO title is chief.
I have a meme for you on this one. It's called the billing record, not the medical record. It should be called the billing record. But anyway, let's get into this AI and strategies. I think this is everyone. We've been talking. We're just going to hear more and more with it this year too. But just where do we start with this, and how do you guys, with what you do at your organization, make this boring stuff, denials and appeals and utilization, give it some flavor, let's make it exciting.
So we, as my boss likes to say, we got into AI before AI was sexy. So our first AI model was back in 2015. And a big reason we started incorporating predictive AI models. So this is not like the ChatGPT generative AI that you see now. These kind of gives a probabilistic output that you make decisions on. But we recognized our analytics that were only looking at structured data like lab results, blood pressures, age, things like that. We're missing all the rich information that's in physician notes, radiology reports. And that's when we really started incorporating AI so that we had a very comprehensive score on each patient that the end user could make actionable in deciding around, should this patient be an inpatient? Am I missing an opportunity for a higher level billing state based on their medical condition? And it really was about getting rid of a lot of the manual work, because UR is very manual. And the staff are hidden typically in the basement. I think I've seen the basement of every hospital across the U.S. And it's, not that you don't have good people. It's just there's so many data points you're trying to keep, in track of. And so it was like, this is a great way to layer in AI into our analytics, automate, and really kind of allow the staff to work at the top of their license. Which is why our clients have seen great ROIs on the back end. And it's funny, you talk about kind of making it exciting. And I know in the early days, particularly when people weren't as familiar with AI, very scared of it, thought we were going to take their jobs. And then when you kind of worked with them, through that change management process, like I would come back and get hugs. I mean, that's, and I think that's, I think we're really starting to see a turn. And I think generative AI is, I think it's very, very responsible for this turn, because it's so, you can touch it, you can feel it, unlike, kind of that predictive AI, but it's really kind of recognizing now what all the problems we can solve using AI. Like you had just mentioned about, physicians hate being in front of the medical record because they, it's a time suck. Like, and so how do we get, the physician back in front of the patient? And a really, if you talk with people that are investing right now, their top 3 will be ambient AI, ambient AI, ambient AI. And it's really cool what is happening with that. Is so you take a phone into the patient's room, like when your primary care doc speaks with you. So you bring a phone in there and it records the conversation. Normally, hours later, I have to remember, hopefully read my notes, and then create a document in the chart.
On the right patient too, right?
On the right patient, yeah. And here it's recorded and it simultaneously creates it into a note format. It's not just a transcription, it's taking that, summarizing it, and outputting it into an appropriate format, and then the physician can review it. And we typically call it pajama time. So it's because you don't have time, you're so busy seeing patients. At the end of the day, you're sitting in your home office at that point, hopefully, and typing out your notes. So it's saving physicians hours and talking about, well, it gives me time back now to spend with my family. So I think I think where I see a lot of things happening now is moving still good skepticism about AI, and particularly generative AI. But I think people are starting to be able to go on ChatGPT, have access to these tools within hospitals, and like really feel how it can help them. And I think that's also what's leading into the strategy that healthcare systems are putting in place, is they're starting to recognize what it can do, and again, with kind of healthy understanding of the risks associated, but where it can really help move the needle in healthcare. And a big one is around summarizing clinical information and putting it in a format to give back time to your staff.
I know we were in the green room before we came on live. You're talking about your, providers, health systems is a big customer, but then it sounds also more of payers, getting into payers. And I imagine with what you were talking about with your algorithms before not algorithms, excuse me, AI, but really it's sounding on the predictive analytics, I imagine. Is that why is that sort of the interest that some of these payers like? Is that you have such rich clinical data sets from all of that you're able to now really have algorithms, if you would, or sort of these models where you can really have a really rich risk score on, and if so, could you get into that? That would,
Yeah, so I think that's, if you typically, think of provider and payer relationships, they're not typically thought of as positive. I give numerous talks throughout the year, and I have a meme. It's the Darth Vader meme. I keep thinking I'm gonna get rid of it one day, but it's kind of like makes fun of a little bit of the image that payers have, and there's like conflicting goals, and a lot of like there's not good transparency between the two entities, which creates a lot of this friction. I think it's fairly easy to pick one side or the other if you're particularly from a vendor standpoint, pretty easy to kind of go on the bad payer side and that. But the thing is we've not moved the needle in this space in years. And so we can't keep kind of like, feel like I should have some it's like the hammer. Oh, I'm not always good at coming up with the little quips, but it's, you know, it's just not working. So I think that's where we've been able to be creative in bringing the two parties together. And it was actually one of the health systems that we work with here in Tennessee that brought a national payer, Humana, to the table and said, "There's, you know, we really like working with you guys. Your analytics are great. You know, you've been problem solvers for us. Can you help us, kind of decrease the friction here and get rid of some of the administrative burden?" I mean, the fact that they still fax things back and forth is like ridiculous. And it's, so what, you know, if you think about it, so on the hospital side, there's a UR nurse reviewing all this clinical information and coming to a decision point. They send information to the payer. The payer has a UR nurse who looks at the clinical information and comes to a decision. Majority of the time, they are coming to the same answer. So it's like, why is everyone doing all of this work? Because it's just a waste of people's time. So our analytics with a high degree of accuracy, both sides audited data, so very transparent process. If the score was over, or care level score was over X, 99% of the time that claim is being paid. And that's then what opened the door to have an agreement between both parties. Again, very transparent. It's not like a black box behind a curtain, you know, on one side. Very transparent, that has allowed us to enter into that. And then we have also better ways to share data in real time, and so that you have less of those kind of data gaps that create issues as well.
Yeah, that seems like we keep on using that word interoperability. If I could in 2025 never hear the word interoperability or lack of that, so maybe you're helping that.
We're trying anyway, and you're going to continue to hear that word. So.
So what are you excited for in 2025 with AI and, you know, as it relates to healthcare?
I think and I mean, part of it's is going to start in 2025. And I think we have to be, we meaning like healthcare, we have to be willing to do a bit of work first. Is that, you know, generative AI, you go on ChatGPT and you ask it a question or ask it to summarize something. Like I like to take really long emails because I don't like to read really long emails, and get it to summarize, and it does a great job. So, you know, you kind of find those efficiencies, but then you also quickly understand where it doesn't do such a great job. And I think that, you know, that we're understanding that. And so, but in order to apply it, you have to be willing to become a little less efficient initially to gain, you know, those kind of long-term efficiencies. And I think part of it is, and we're a big proponent of human in the loop. We're not at a point where the AI can just be off doing its own thing, particularly generative AI with no like ability to edit, input, and things like that. And so it's figuring out how that relationship works. And I really do believe in the next couple of years, and I don't think this is like 10 years down the road, I think this is going to happen fairly quickly, is, you know, you're not going to get rid of physicians, you're not going to get rid of nurses, but the way we do work is going to change. And I think that's where we have to be willing to put in some time as physicians, as nurses, to, you know, if there's a pilot program going on, like raise your hand and be part of that conversation so we can figure out how the two marry together in workflow. So that's kind of what I'm excited to be. It was interesting. I was at I can't remember if it was a conference or a webinar or something. But again, I think this speaks to the age of some of us physicians, is we're probably the last generation who learned the way we learned and practiced the way we practice. And AI is going to be a big player in what the next generation does. And so I'm a little jealous, but also just kind of excited to see how it rolls out.
Can you share a little? I thought something you said earlier was very interesting, fascinating, that you have the data scientists reporting rather than like the CTO, Chief Technology Officer. They're reporting, I think that says a lot to the chief medical officer of your organization. Can you give us a little bit of that and how that works and how you're involved in that?
Yeah. Again, I think to some degree I fell into it because I've always had a strong interest in tech and kind of AI. Just fell into that when we first brought on our data science team back in 2015, 16. We had one individual on the team at that point in time, and like I would literally, I mean, poor Jason, I think, I drove him bonkers because I just thought this stuff was fascinating. And, I had to like pull myself away from learning how to code again. I was like, no, Heather, stop, step away. But I mean, part of it was I love to learn new things. And so I just found this a fascinating space. And I think I fairly quickly recognized the opportunities, within healthcare and within our own company. And then I also call myself the AI whisperer because I think sometimes you need someone to translate between kind of the, very kind of, black and white, very technical space of data science and, all the technical details behind the models to kind of the all the way up to the C-suite to understand what it does well, what it doesn't do well, what the limitations are, where it opens up for risk and things like that. And so I think I kind of fit, I think all of that is what led me to, the role that the oversight that I have now. So I spend a lot of time with our data science team and then also with product. Because they're the ones that we're in a build and we're doing more work in case management and discharge planning and interoperability as well. And so we need to align the outputs of our AI models, our generative AI, so that they work within the workflow and the goals and the business, goals that we have in place for those products. And so there's a strong tie between data science and product, and then obviously also a tie with our engineering department and ensuring good. So it's a very collaborative position, which again, I really enjoy as well. And then you get to do cool things like this. So.
Yeah. No, this is cool. I love, I do this because this is how I learn. And I love having people on like yourself that are, in the process of, making healthcare better. Tell me a little bit about like if you could, I mean, this would probably be better if I put up on the screen, but just a little bit of the process, like, what it looks like for the utilization review, like what's going on, like maybe behind the scenes, and then also sort of like really the user interface, if there is, or just sort of the process, starting with the process, like at the user, I guess the nurse review or whatever.
Yeah, so we get a very rich data feed from the electronic medical record, and we try to do a lot of the work on our end because IT systems, healthcare IT systems are just like pressed for time and all that. So we try to facilitate that. So it takes a couple of months for us to go live. So during that go live period, we spend a lot of time understanding the workflow of the UR staff at the hospital, because it does vary hospital to hospital. We also spend that time providing education as well, because there is a change management piece to AI, making sure people understand we're not taking their jobs and getting them comfortable with new outputs. Because as I'd mentioned earlier, UR has historically been a very manual process. And so we're really kind of introducing a very new way to think about work within the UR space. And so we are software as a service or SaaS. And so the user does log into our platform, and a lot of times you're responsible for a floor. So maybe I'm responsible for all the patients on the 7th floor, and so you have your work list of patients, and then we have action items based on our main output is called the care level score. So if it's a high score, more likely inpatient, a low score, more likely observation or outpatient. So that score is used to drive workflow. So they can go into our Dragonfly application and see very quickly these patients are likely in the wrong status based on the care level score. So that's what drives them to then start their day with those patients because they have the highest risk, there's potential revenue leakage, instead of kind of just working one by one and then maybe missing those patients at the end of the day. So it's about, so they have ways to kind of go into different subsets of patients based on risk or opportunities. And then, and so that is then what allows you to capture things early instead of later in the stay. They have ability within the platform to seek clinical information, and it's meant to be, it's designed to be much more appropriate for UR than if you're in the EMR, because the EMR, there's just like everything's in there. So it's a much more unified view that allows quicker review of the clinical information. Because again, it's still that, incorporating human in the loop. So really high score, you probably just minimally have to look at a couple of things. It might have to send some information to the payer. And so we help facilitate that communication with the payer. Payers have access to our portal as well. And so they can see real-time information. They can communicate back and forth. Your staff typically work with physician advisors as well, so they can communicate and task cases in there. So it is a very comprehensive workflow. And then that information is then available to other entities, which we can feed back to the EMR if needed, because you're not going to get your day-to-day physicians out of the EMR. That's their primary workflow. So if there's relevant information for them, it flows from our system into the EMR, and we can feed back other information into the EMR where other departments need to have access to that.
So as an organization, what are you doing to try to, I know, it's with technology, I guess the thing is, if Henry Ford gave the customers what they wanted, it'd be a faster horse. What do you do to drive innovation and make sure you kind of time it right? Do you guys have skunk projects in AI that's like way not ready to just right? How do you do that as an organization with AI?
It's funny you talk about it'd be a faster horse. I stole this slide from a conference. I think it was a HIMSS conference I was at, and they were talking about innovation in AI, and it wasn't that you made a better candle, because there's a leap. It's not like it's taller, more wax. Like you move to a light bulb, and then you move to like a. So it's kind of reminded me of that with the horse there. No, we do have. We allow our data science team a percentage of time free to them to experiment with things. So that will allow them to experiment with different techniques. Because there's, as you can imagine, particularly with all of the blogs and open source, and they do. I just blanked on what those the hackathons. It exposes them to different techniques, and then they will take those techniques when we retrain our models to see if there's an opportunity to improve them with it. So there's that level of kind of innovation. And then we do, like our different product teams will bring ideas to data science. And some of them, you sometimes get asked to cure cancer, and you're like, that's maybe a little too big of a project. We maybe break it down. But we'll get ideas, from the product teams, and they'll do kind of quick 2-week iterations to see if it's something that's viable, and then we want to put a business case around and kind of build it out. So, and then we also have some pathways for our employees to come up with, hey, could you help us? We're having this issue. We recently had marketing come to us to helping to get leads into the appropriate categories. So there's different ways, but I am pretty proud of the fact that we do a lot time for data science to kind of have a little bit of free reign, not just like you tried this and you try that, and it's allowed some really interesting approaches and ways to tackle problems to bubble up to the top.
So what is the biggest thing holding back, you think, AI? And this is like separate from healthcare. I know this is you're a healthcare company at the core. Of course, you're chief medical officer. I'm just thinking, because you're in Nashville, Tennessee, I'm thinking of Memphis, Tennessee, with this XAI, 100,000 houses of power for this colossal, this computing thing. What the heck could you surmise real quick on what's going on with that, and what are we going to see with this NVIDIA, like it's 100,000 NVIDIAs, and we might see up to 1 million. How does that in the ecosystem of, like you said, trying to not necessarily task your data scientists cure cancer, but I just threw out like, little whatever spitball up against the wall. So
yeah, it's interesting. I think I read somewhere that, and I don't know why it's called Grok. I think the XAI's LLMs I think Grok 3 was supposed to come out, but is not. So I don't know why it did not come out. Yeah, I don't know. It's I think and I probably sometimes like to put the glass half full lens on, because I really do see the promise with AI, and I think we really need to lean into it to really realize it. But there are inherent risks with it, and I do worry that either the Musks of the world are going to it's going to get ahead of itself too quickly before we understand all of the ways we need to regulate it. I get a little worried about, I mean, you already see it now, when you talk about deep fakes. And I mean, right now, so, anyone can come on the internet, take your voice, take my voice, create a communication saying anything using generative AI, and, call your, I mean, unfortunately, elderly folks are very susceptible to this. Like you mentioned earlier, my parents are in their mid 80s, and my dad, very tech savvy, and he fell for something slightly ridiculous recently. But like, they could simulate me calling. And so I'm a little concerned that some of these things the press is going to get hold of and kind of create a fear factor. And some of it's going to be legitimate, and there's definite risks with cybersecurity, cyber attacks. I mean, we've seen more and more, particularly in healthcare. There's been some really big ones in 2024. So I think it's how disruptive that is in kind of moving the good stuff forward. So I think that'll be interesting how that plays out.
Yeah, so we've told all our parents that code word, don't ever, if someone grandchild calls and it's like, I'm stuck, Grandma, I need $5,000. I'm over in Europe and I need you to send me some money. I can't get back, or whatever. No, you make sure you call whoever directly. But anyway, I guess or the safe word, I guess we're supposed to come up with the safe word, right?
Yeah. I think, what was that when we were kids? It was when we were kids, it was like, you don't get into a stranger's car, and now you get into Uber. So yeah, I'll be curious how next year plays out, and I'm not a huge fan of bringing up the political piece, but I do think that's going to play a role in some of the regulations. I actually think there'll be deregulation coming up next year. Although, interestingly, Elon Musk did make a statement, I think it was in the summer. California, a lot of states are putting regulation in place, and California was coming out with the most restrictive. Governor Newsom did end up vetoing it but before it was vetoed, Musk actually was in favor of that more restrictive regulation, which kind of goes against what you would expect from the incoming administration. So I'll be curious what happens from a regulation standpoint there.
Yeah, I hear that there's regulation with these things on a day-to-day, but then not for industrial military use. It seems like everything's regulated except for those sort of things. Like we still don't know about these drones, the 800 to 1,000 drones over New Jersey. So anyway, I feel like that's still in that's in the same sort of category of these unknown technologies, and all of which I'm sure we're using there's some AI within them, whether they're automated or whatever. But we are really, I guess when you have a show like Planetary Health First, Mars Next, you kind of get off topic on things. So want to bring us back to healthcare. So really glad you're on. And so give us a little bit about what, I don't know, are you going to be, is your company going to be at some conferences this year at Vive or in Nashville, I imagine, and maybe HIMSS? What are you excited about? Sort of the things that you would see with going on at that?
Yeah, so we try to be very present at quite a few conferences. There's conferences that really speak to our end users. So we are at the ACMA National and Leadership Conferences, which is American Case Management Association. They actually had it in Nashville last year. They did their 25th anniversary there. And then we attend several physician advisor conferences because they're an end user of ours. And then we'll be at HIMSS. I believe we're at Vive this year. I'm not 100% on that one, but I do enjoy, and then I try to go to several AI specific conferences more on the healthcare side. I went to a very good HIMSS one this year. I've been to AI Med before. I kind of actually like those to select a few that I'm not speaking at to kind of take that pressure off. But I just think they're great avenues to not only speak about all the great work that we do as a company in helping both providers and payers, but also I'd like to kind of speak with people and provide even just education around AI, because I think if you don't spend the time learning about AI, how it can help you, its risks, you're going to get left behind. And I think it's key to making good decisions in healthcare around, what vendors you should bring into the mix, like how you vet vendors that bring AI. So I really like going to conferences and learning, and then also trying to, provide as much education as possible.
So I think this, as we're coming towards the latter part of our talk today, I think what would be really helpful is just if there's any insights to, I guess, is there titles now? Like, are we seeing it across the board? Chief Artificial, Head AI Officer, and what does that entail? And what if they created that role or that requisition, and sort of what should be guiding to get it right, to push it, to pause. Sort of give the parameters of what your thoughts are on that from an organizational level.
Yeah, so there is really started to see it last year, Chief Artificial Intelligence Officer. So we're kind of really elevating that to the C-suite. And I think historically, like kind of chief data analytics or whatever, previous titles would be, it tended to be more technical people. I think with the Chief Artificial Intelligence Officer, particularly in healthcare, and I'm sure it's true in other verticals as well, but in healthcare, I think you need someone that really understands like in the hospital, the workings of the hospital, that has, and you'll see several that actually are starting to be physicians or have a clinical background. Is I think you really need to have that grounding. You don't necessarily need to understand, all what a vector database is and, in gory detail. But you do have to have some technical chops. You have to have spent the time to understand, so you can have that meaningful conversation with your data science teams. But I also think you have to have a grounding in processes, because data governance and AI governance is key to that role as well. Because a lot of times, a lot of health systems will build their own AI, but then they'll also partner with vendors, because you can't build everything in-house. And so that role is very important, and not only setting the foundation for your internal strategy, you're getting buy-in from key stakeholders and end users within the hospital, but then also having the ability to work through governance processes to bring in vendors appropriately and manage that whole ecosystem.
I liked how you said the governance. It seems like governance is really the core of it all. It's not just technology, it's the governance, what the process, how it is to just ensure privacy, safety, and how are you going to do that?
Yeah. So that's it was funny when I used to get on calls. We'd have during the sales process, meet with the CIO or CTO, and they'd have just a couple of questions around AI. Now, when I get pulled into some of these calls, or we get these questionnaires, 100 questions that you have to fill out. So it's a much more rigorous process because healthcare systems are recognizing you have to put that governance in place and do very thorough vetting of your internal processes and your external processes. There are some organizations out there that are really kind of laying the groundwork, because it's a very, it's changing every 5 minutes. You saw how quickly iterations of ChatGPT came out last year, but it's a rapidly changing place. So these organizations are kind of helping set the groundwork. So instead of waiting for whatever's going to happen next year, policy coming that way, is being the leaders in setting the policy instead of kind of having to play catch up. So CHI is a really big one coming out of Mayo, and Stanford really kind of helped lead that, and they're coming out with checklists and best practices. Responsible AI Institute's doing a lot of great work as well. So those are excellent resources to help build out programs that you have, either from a vendor standpoint or from a healthcare standpoint. And then a lot of the conferences will tell you this is what you need to do when you're working with a vendor, so that you ensure that they have good processes in place, and it's not it's not kind of smoke and mirrors you're entering into.
Yeah, I know there's been so many that just add AI, or just,
I know.
It seems like to raise more capital or whatever. So it's really sussing out what is legit and what is not. So
yeah.
As we're coming towards the end, any sort of parting words? I know you got into some good stuff just a little bit ago with best standards, practices, and thoughts for 2025 with AI that you'd like to leave us with?
Well, I think one thing that I'm looking forward to, from a physician standpoint, is it's we're moving into the future to go back to the past. Because if you think about it, you watch those, older movies, and the physician is holding the patient's hand and looking at them in the eye, and having a more meaningful conversation. And now there's a computer in between. So I think it's how do we get the computer out, using and kind of bring that patient physician relationship back, because I think that has been lost. It's just become a machine, and I think I think patients have suffered for that. So I think that's a big thing that I'm hoping for coming out of this from a physician standpoint.
Yeah, I like that. So I'm taking, when you said that, I just thought of the word trust. How do we restore trust?
Yeah.
That real trust. And I think I'm hoping maybe that's AI 3.4 something. I don't know.
Yeah.
Really restoring trust. And I'm really glad that you came on. You are my first podcast guest. Okay. for 2025. So really appreciate you coming on today. It's been great, Heather.
No, this has been awesome. Thank you so much for having me and allowing me to kind of kick off the podcast season for the year.
Yeah, no, absolutely. And so if there's anything, if your team or you would like to share, what I do is when I post this afterwards, I then put it into my Substack, my newsletter. And what I always love to do is to have some complimentary resources or references that are appropriate with what we're talking about. So maybe some of those, organizations or to help with, AI or guidance or governance or anything that you can think of would be really helpful just to make this a better, a fuller newsletter and talking points.
Yeah, and you have Stacy's contact info.
Yeah.
Help facilitate all of
Sure.
all of that.
Yeah. All right. Well, I will definitely get that and we'll put that on the newsletter, but it has been awesome. And I am going to send us off real quick. 1 second. We have our little ending little